William Maega, a lecturer at the Makerere University School of Public Health. I hold a basic medical degree, an MPH, and a PhD in medical science. We are going to talk about validity and reliability of screening tests. In the first part of this presentation, we are going to look at why and how to validate epidemiological tests. By way of background, in the health and social sciences, we make extensive use of measurements. Measurements might be aimed at identifying people with certain conditions of interest. Measurements include, for example, clinical assessments, where we take history and do physical examination. They may include physical measurements. We may take people's height, take their weight, take their length, and do anthropometric measurements. We may do laboratory tests to test for diseases. For instance, we may test for malaria, we may test for STDs, we may test for infections. We can also do social assessments. For instance, we can assess people's socio-economic status. We can assess maybe stress levels. We can also use questionnaires to assess social attributes. We can assess frequency of diseases or conditions of events in whole populations. In general, every measurement we conduct to identify disease or people with a certain state can be viewed as an epidemiological test. The key challenge is that tests differ in their level of accuracy or consistency in telling us what we want to measure. As illustrated in this picture, measurement is the spice of life. Even in everyday life, we compare ourselves with others. You look at someone and you say, does this person's shirt or does their blouse look as good as mine, or is it better? So we keep comparing ourselves to others. But are our comparisons valid? This is what we want to look at today. Now, we are going to discuss this mainly in the perspective of screening and screening tests. In epidemiology, we do screening. In screening, we want to identify as many people with a particular disease or health-related event of interest as possible so that we can initiate remedial action in time. Why we need to screen is that from the outside, we do not know these people. They may be asymptomatic. They don't have clear symptoms that are easily identifiable. So we want to be able to spot them from within the general population. So we apply screening tests. Examples of where we apply this is, for instance, we may want to detect people with sexually transmitted diseases, breast cancer, Ebola, HIV/AIDS, diabetes, hypertension, and indeed many other health-related conditions or events. We may, for instance, want to know who uses protection during high-risk sex and who doesn't. We need to apply screening. Now, the key challenge is to get the test that we can apply at the population level and a test with sufficient accuracy to get us what we want to learn. Now, you may ask, why not use the gold standard? Why not screen the population using the gold standard test? Gold standard tests are not used for massive public health screening, mainly because they tend to be invasive, they tend to be expensive, or they tend to require high technical expertise. Take, for example, the gold standard in radiology, which could be magnetic resonance imaging or CT scan. This is a tool, first of all, which is very expensive. Two, it requires someone who is very highly technical and very well trained to be able to use this tool. So to apply it to screen massively a large population of people, either in the entire country or a region or a school, would be very expensive, but would also be technically prohibitive. Another example is HIV/AIDS. The gold standard for HIV/AIDS would require you to detect the viral DNA, or indeed to see the virus in an electron microscope. We neither have these tools at the primary healthcare sites distributed everywhere, but even if they were there, they would require a lot of technical expertise. So for screening at the population level, we have to identify simpler tests, cheaper tests that can be applied massively to detect as many people, to screen as many people as possible, so as to detect the few people with the disease condition. But the catch is that the simpler the test, then we are likely to have challenges with validity for the test. So what then is validity? Validity refers to the extent to which a test measures correctly what it is intended to measure, or it is the ability of a test to correctly differentiate between who has a particular condition, either a disease or health-related state, and who does not. Now, validity has two parts. It has what we call sensitivity and what we call specificity. Sensitivity is the ability of a measurement or a test to identify correctly those who have a particular condition. If it is disease, the ability of the test to detect those who have the disease in reality. And specificity is the ability of a test or a measurement to identify correctly those who do not have the condition. Those who do not have the condition. Now, it looks intuitively, you may think that one should be the automatic opposite of the other. A test can be good at detecting people with a particular condition, but it is not good at, it's not very accurate in detecting people without the condition. So, and it could be also vice versa. It may be very good in clearing those who don't have the condition, but it also misclassifies some of those who have the condition as not having the condition. So we want a good balance. Now, how do we then determine validity of a test? How do we validate a test? Now, to validate a test, we have to use another test which is the gold standard. The gold standard is the one which determines that this person has a particular disease condition and this person does not have the disease condition. So let us assume that the gold standard is 100% perfect. When it says you have the disease, you actually have the disease. So it will classify people into those that have the disease and those who don't have the disease in actual reality. Now, after doing that, then we apply our proposed primary healthcare screening test. First to those who have the disease, and then to those who do not have the disease. And then we detect the extent to which the two tests are able to concur. Now, I will illustrate this with a very quick example. Let us take, for instance, a population of 100 people. 100 people taken from the population. And we apply the gold standard because the gold standard will tell us who has the disease and who doesn't. So you imagine that the gold standard tells us that 20 people actually have the disease, in reality, actually have the disease. And that means that 80 people do not have the disease. So we denote that as no disease. So we first use the gold standard, and the gold standard will tell us those who have the disease and those who don't have the disease. Now, then we apply the public health screening test to first those who have the disease and then those who don't have the disease. So I will denote it as PHST, meaning public health screening test. So first, let us focus on the 20 who have the disease. So you imagine that my test is, out of these 20, is able to say that, to identify 15 as being, I'll use the word positive, because we are not very sure that they in reality have, that the test is correct. So out of these 20, let's say that it says 15 are positive. So the test agrees with the gold standard that 15 of them have the disease. That means that for 5 people out of the 20, it says they are negative when actually they have the disease. They actually have the disease, but it says they are negative. So because they actually have the disease and it says they are negative, we refer to these as false negatives. So they are false negatives. On the other hand, the 15 where it concurs that they are positive and they have the disease, we usually denote that as true positives. Now, after dealing with the people who actually have the disease, we then switch to those who don't have the disease, the 80. Now, you imagine that our public health screening test, out of this 80, it says that 72 are negative. That means it agrees that out of this 80, it identifies 72 as negative. It means that 8 are incorrectly classified as positive when they are actually not, they do not have the what? The disease. So we usually denote these as false positives, while these are true negatives. So just to recap very quickly, we get a population of people, a sample of people. We use the gold standard to identify those who actually have the disease, who in reality have the disease, because we say the gold standard is always correct. We are presuming. That means 80 do not have the disease. Then we apply our public health screening test first to the people who have the disease. Say we identify 15 as positive and 5 as negative and this. So when we get this, we can summarize these findings in what we call a 2x2 epidemiological table. This 2x2 epidemiological table is very important in epidemiology because it's quite commonly used to classify findings from such assessments. So usually in the 2x2 table, we put the gold standard on top. So this is the gold standard. And we say the gold standard determines that someone has disease or no disease. And then on this axis here, we have the public health screening test, which is either positive or negative. It's either positive or negative. You see? So we have situations in which both the gold standard and the public health screening test agree that this is positive. And this we said are called the true positives, in which case, in this case, there are 15. We have situations among the people with the disease where the public health screening test says that they are negative. So they are false negatives. And these, in our example, are 5. And remember that the total, when you add the column, the people with the disease, remember we first focus on the people with the disease, the total is 20. That means this side, since the overall total is 100, here we have 80. Now of these, of the people, so we switch to those who are negative, who do not have the disease, the 80 who do not have the disease. Your public health screening test is able to detect 72 of them. That means it misclassifies 8 as false positives. So these are true negatives. And sometimes, algebraically, we denote this as A, B, C, and D. So we fill the information in a 2x2 table. The totals here of the 2x2 table represent, on one side, the people with the disease, and on the other side, the people without the disease. and then the distribution of how the tests agreed in each of these. Now, we are then able to determine sensitivity. So the sensitivity of a test is the proportion of those who actually have the disease that your primary healthcare screening test is able to detect. So if we look conditionally only on those who actually have the disease, the 20, your test is able to detect 15. So the sensitivity of this test is 15 out of 20. And then we usually multiply by 100 to remove the decimal points and present the sensitivity as a percentage. In which case, we have 150 over 2, which is 75%. So the sensitivity of this test is 75%. What does this mean? That out of every 100 people who in reality have the disease, who actually have the disease, this test is able to identify 75% of them. So given that you truly have the disease and you are 100 people, this test will be able to identify about 75 of you and correctly classify you as having the disease. It means, therefore, that 25% of those who actually have the disease are misclassified as false negatives. So false negatives, 25% of them. Now, the specificity, on the other hand, is the proportion of those who do not have the disease, that is B plus D, that your test is able to detect as not having the disease. In our situation here, specificity is given by, so out of the 80, your test, our public health screening test, is able to detect 72 of them as not having the disease. So 72 out of 80 times 100, which is 720 over 8, which gives a percentage of 90%. So the specificity of this test is 90%. It means that if you bring 100 people who are disease-free, they're actually disease-free as determined by the gold standard, which we are presuming to be fully accurate. Your test will be able to detect 90 of them and as testing negative. That means 10% are misclassified as false positives. So when we roll out this test for primary healthcare use, we know its sensitivity and we know its specificity. We know that whenever it returns a certain result, that result has to be interpreted in light of its sensitivity and specificity. Now, let us look at an example. Imagine a population of 500 people, of whom 100 actually have a disease and 400 do not have a disease. Who determines that? It's the gold standard. It's the gold standard which determines that these actually have a disease and these do not have the disease. So imagine also that the 500 people are subjected to a public health screening test to identify positives and negatives. And imagine that among those who actually have the disease, the test is able to identify 90. And then the test misclassifies 110 people as positive when they are not. So we need to calculate the sensitivity and specificity of this test. As I said, the starting point is to summarize the information that you are given in a 2x2 table. We said the gold standard is on top, and then the public health screening test is on the side. And so we have the disease status. For the gold standard determines the disease status. So we have disease and no disease. And then for the public health screening test, it returns a result that is either positive or negative. And then we have the total. So from the information we are given, we have a grand total of 500 people, of whom they say 100 actually have the disease, as determined by the gold standard. So 100 actually have the disease. So it means that 400 do not have the disease, which makes the total of 500. Now, they say that among those who actually have the disease, the test is able to identify 90 as positive. So 90 as positive. So of the 100 who actually have the disease, the test is able to identify 90. It means that the test will misclassify the balance as false negatives, which is 10. Now, on this side, the test is, they say that the test misclassifies 110 people as positive when they are not. They do not have the disease. That's the information you'll be given. So they do not have the disease, but it misclassifies them as positive. So we put them in this section. So that means the balance, 400 minus 110, is 290. So then, with this information, we are able to compute the sensitivity of this test, which is the proportion of those who actually have the disease that it is able to classify as positive, which is 90 out of 100, which is 90%. And the specificity is the proportion of those who don't have the disease that your test is able to correctly classify as true negatives. So that is, so specificity is 290 over 400 times 100. I said we multiply with the 100 to create a percentage, and actually we get 72.5%. So the sensitivity of this test is 90%, and the specificity is 72.5%. So there on the screen is what we have just done. We summarize the information given in a 2x2 table, and then we compute the sensitivity and the specificity. Now, we have all along been dealing with dichotomous variables. You can see that with the gold standard, we deal with a person having disease or no disease. And with the public health screening test, we are saying positive or negative. The situation becomes a little bit more complicated when what we are measuring is a continuous variable. Take the example of blood pressure. The blood pressure is a whole range of values that follow a normal distribution, if you can see from here. We have most of the people being around the mean, but there's a whole range of distributions of systolic blood pressure, some as low as 80 and others as high as 160. How do you determine the cutoff that this person has high blood pressure and this is a normal blood pressure? That is a challenge. So in order to be able to deal with such kind of variables, we have to establish a cutoff, and the decision is made on the basis of the cutoffs. Now, there's a catch in dealing with continuous variables and establishing cutoffs. If you set a high cutoff, you increase the specificity of the measurement because you reduce the false positives. But unfortunately, you also reduce the sensitivity of that test. Conversely, if you lower the cutoff, you increase the sensitivity, but you also, because you reduce the false negatives, but it results into a net reduction in specificity. So those are the challenges. If you set a very high cutoff, you'll have a very good specificity. That means you'll have very few false positives. You'll have very few false positives, but you're likely to have many false negatives, so you reduce the sensitivity. Likewise, if you lower the cutoff, you reduce the false negatives, so the sensitivity will increase, but the specificity will also reduce because you are likely to increase the false positives. Now, the methods for determining cutoffs for continuous variables are outside the scope of this lecture and would be handled in more advanced sessions. Likewise, the methods for dealing with multi-level variables, here we've been talking disease, no disease, but what if we had mild disease, moderate disease, and severe disease? That is multi-level outcomes. We will not be able to do a 2x2 table, but we need to do a table with many categories. So the methods for that will also be handled in more advanced sessions. Now, before we conclude the first part of this presentation, we have to look at why do we need to validate tests before we put them out for use at the public health level. And it reminds me of this saying, do unto others what you would like to be done on you. It is ethics. So you imagine with false positives, the emotional consequences of telling people, for instance, that they are HIV positive when actually they are not. Or if you get so many false positives coming to the health facilities, you will burden the health system because the health system will be treating many people who do not have the disease, but they will be giving them treatment. This will lead to wastage and also take up health workers' time, but also will lead to costs to the patients because they have to incur transport and that. I'll give some examples, some illustrations. Think about telling someone that they are HIV positive when actually they are not. Or think about over-treatment of STDs, and I will illustrate that. In our primary healthcare system in Uganda, we use a very simple screening test for STDs at the Health Center 2 and Health Center 3, and it is called the syndromic management of STIs, syndromic management of STIs. So the primary healthcare screening test is a chart that uses symptoms to classify people and therefore initiate treatment. So the chart was developed and discussed at by experts at the global level, and it was determined that it has some very good properties in terms of finding most of the people with STIs so that they can be treated. And very quickly, if I go through it, it uses, like I said, it uses syndromes, and there are 4 plans. Plan A says if someone comes with a whitish discharge, so whoever comes with a genital discharge, a man or a woman with a genital discharge that is white or cuddly or milky, treat with, for example, antifungal drugs like nystatin. For instance, if they are women, you give them nystatin pessaries to treat. The presumption is that people who come with a whitish discharge have candida. But what if someone applied powder and they applied a lot of powder and they got uncomfortable in their genital areas and they came to you? You are likely to classify that as candida and you start treatment with candida. So the advantage of this chart is that it will find most of the people with candida, but it will also misclassify some of the people without candida as having candida. So therefore, there will be false positives. So it has a good sensitivity, but the specificity is low because it has a high number of false positives. And plan B, it says, plan B, any discharge that is not white, any discharge that is not white, and they have a set of antibiotics that you're supposed to give those people. And the presumption is that maybe there's a bacterial infection or another infection like chlamydia or bacterial vaginosis. So give doxycycline, give ciprofloxacin. So you see, if you came with other problems of poor hygiene or urinary infection that is creating a non-clear discharge, you'll be classified as having an STI. Now, in Plan C, it says whoever comes with a genital ulcer, you treat with an injection of benzathine pen G. So it assumes that if you have a genital ulcer, this is syphilis, for example. But it could be anything. It could be there's herpes simplex, which is fairly common in Uganda. It could be that someone has a pimple in their genital area, but it misclassifies it. Lastly, Plan D is lower abdominal pain, which it presumes that this could be sepsis. So, and it has a set of antibiotics that it gives, that this could be an infection of the reproductive organs. And yet, it could be just pain, coincidental pain. You see? So, the chart itself is very good at identifying many of the people with suspected STIs, but it also misclassifies and has quite a number of false positives. So it has a high sensitivity, but it has a lower specificity. But you will understand why it is used, because in many of these health centers, we don't have the laboratory tests that can test, say, for syphilis, for this gonorrhea, and these various other infections. So that's why it could be a useful tool. And I always conclude this first subsession by talking about a personal story. When I used to work in Chiboga, and this young girl comes, and she has all the signs of meningitis. She has a stiff neck, she has a fever, she's unconscious, and she's convulsing. And she's treated for 3 weeks. A lumbar puncture is done, and it shows that there are some infections, some pus cells in the cerebrospinal fluid. And then after 3 weeks, when everybody was away from the ward, this girl opens her eyes and whispers to me that, actually, doctor, I don't have meningitis. You people are wasting your time. And then I said, what is the problem? She said, I am pregnant. So the tests, the clinical tests that we all did were all not valid for this category of a young, pregnant, adolescent youth. We need more valid tests to be able to detect psychosocial problems in this group. So probably it was pointing to the fact that she was so overwhelmed, and she had a very big story that she could not open up very easily about. Now, with regard to false negatives, think about missing a potentially serious condition. You tell someone that they don't have breast cancer or cancer of the cervix, but when they actually have it, and for many of these cancers, the best chance of survival is when they are detected very early, in their earliest stages. Think about the blood bank. Think about the blood bank. False negative units of blood in the blood bank, and you issue them to be given to patients. Same applies to organ donation. So this is the end of the first part of this presentation.